choosing a specialist using data versus opinion. And this is our proverbial Quizzify dog and pony show. And I'm going to start by making some introductions to get us going here. I'll introduce myself first. This is Mark Dillabough. I've been with Quizzify for about 5 years. Prior to that, I had worked in the brokerage industry with Willis and USI. And Al and I have been doing these presentations with complementary vendors. In many ways, it's health literacy for the broker and for the benefit manager side of the business versus our core business, which is health literacy for employees. Al Lewis is on the call with us today. And as most of you know Al, and Al is recognized as one of the foremost authorities on wellness and population health. He's authored a book about that. He wrote another book that was about cracking health costs with Tom Emmerich at Tom Managed Benefits at Walmart for more than a decade. And back in 2013, they were talking about better pharmacy benefit management, better medical management, centers of excellence. Many of these strategies are now going mainstream in next generation benefits plans. And Al is also a Harvard-trained lawyer, and that spills into our ER Prevent Consent, which has been working to save a lot of people money from surprise bills in the ER. Now, we're going to be talking about data today, and we have some expert panelists with us. Ed Dillabough is president and co-founder of Map Health, which is now owned by Sentry Health. And Ed built a business that essentially mines this data that helps people to make better decisions when choosing a specialist. And Ed is joined today by his colleague, Colleen Hickanen, who manages a group there that she's their chief clinical services officer. And this is a team of people that interacts directly with the employees and employer group to help them understand why they might want to use a certain specialist that comes up in data and guide them into their best possible health. So engaging employees to use this data is also an important part of this process, and Colleen will be talking about that as we get into our conversation. But let's talk about our agenda. We're going to talk about some polling questions to start us off. Where does this data come from? The components of specialist quality and cost decisions when choosing a specialist, engaging employees to use this data. And then once you've found a specialist, what do you do? What can you get prepared for that doctor visit with the right questions to ask? And Quizzify to Go can do that. Al's going to talk about that. And we're going to also have a Quizzify challenge to wrap after that. So let's start with some polling questions. I'm going to put up 2 questions on my screen here, and we're going to have you take a look and answer these questions in terms of how you pick a specialist right now, and another question about diagnosis. In the meantime, Al Lewis is going to share a story about his efforts to pick a specialist.
Yes, I am here to learn as much as anybody is, because while Quizzify claims world-class leading expertise in, as Mark said, what questions to ask when you get to the specialist, health literacy, and certainly ER, I don't know the first thing about picking a specialist. That's why we have these folks on. And I've picked some of the worst specialists in the history of specialists. So to give you one example, this is just one, and hopefully I have time for all of them. I had back pain. Now, Quizzify teaches quite correctly that 80% of back pain goes away on its own eventually, but 80% of us are convinced at some point that we are in that other 20%. And we go seek medical care, and that's exactly what I did. I went to my PCP, and oh, hang on, there's a message here. Can people not hear us? Oh, I'm sorry. The answer is, no, I'm sorry. Back to the storyline. So I go to my PCP. She refers me for my back pain to an orthopedist who pokes me a little bit and then announces I have piriformis syndrome. And that was kind of the disease du jour back then. And I say, what's piriformis syndrome? And he says, quote unquote, look it up in any sports medicine encyclopedia. Okay, that's not even the punchline. The punchline is I go to look it up. And it turns out, so I can't find it. I'm looking PER, PIR. Never occurred to me that this was PYR. piriformis syndrome. So I just, I got nothing out of that visit whatsoever. It took 5 minutes and I was billed at a level 4. So I'll just stop there because I can keep going on how to do things wrong all day. Let's see what the answers came in as. Mark?
Okay, now for the question, how do you choose a specialist now? It's 51% said PCP referral, 16% I ask a friend, 24% I search on my health insurance network, and the 9% said a friend recommends one. In terms of what percent of patients visiting at the Mayo Clinic for a second opinion learned that the initial diagnosis was truly accurate, the 49% said 50%, 27% said 70, and 11% said 80. And the actual correct answer there, unfortunately, is 12%. That's a bit of a shocking study that was done by the Mayo Clinic, but the reality is that misdiagnosis is a little bit more prevalent than people realize, and that makes choosing a specialist, a quality specialist, more important than ever. So this now spills us into actually, so where does this data come from? And Colleen, I'll ask you to talk to us about that.
All right, sure. I'd love to kick us off. So we saw that 51% rely on their primary care physician to direct them to a specialist. And I think this is like the perfect analogy when you're thinking about just navigating the healthcare system. You are in treacherous waters, right? And when you think of the Titanic and what brought the Titanic down, it was the iceberg. It was what they could not see under the surface of the water. So a lot of our patients, when they're looking for identifying a quality provider, they rely on people like their primary care doctor to steer them, or they're looking for referrals from friends and family. And I think they're really focused on kind of what they know above the surface of the water. So they're looking at, some convenience factors. How close is that doctor to them? What are some appointment availabilities? If they were given a specific name, usually they'll go and the first thing they do is they go on Google, right? So they're looking maybe at what's the doctor's background or educational history. They may even look at some Google reviews. So, that can be a little bit more dangerous than helpful. But it's really underneath the surface of the water. That is how they should be determining what's the best doctor for them. And sometimes it's just not having the knowledge that information is out there. And sometimes it's just not having access to that information. So you want to be able to, when you're identifying a quality provider, look at some different data sources. And you never want to rely on just one data source, right? You want to get a really good mixture. You want to get information from CMS, but you also want to make sure you're getting that commercial payer information as well. And from there, that data should really help in steering and navigating you to the best quality provider. So let's look at what some of those data points would be that you're looking at. All right, so when I started the discussion, I talked about what are some things that patients will typically look at before they make a selection. Educational background is one of the things that they look at, but they're not looking at the right thing. So lots of times I'll hear, my doctor graduated from Harvard Medical School or, a very prestigious medical school, which is wonderful, but they're not looking at things like, is that doctor board certified? Is that doctor fellowship trained? What was the time of their graduation? So you definitely want to consider those types of things when you're searching for a quality provider. You don't want someone right out of medical school doing a surgery or procedure on you. At the same time, you don't want someone that is nearing their retirement age, right? So you need to consider those types of things. Then you really want to drill down into, okay, if I'm having a surgery or procedure, what are the number of cases my doctor has performed? You want a doctor that has very good volume. We see this so much with orthopedic cases all the time, where you have a doctor, a specialist that really specializes in a certain area of the body, But then every now and then, they will perform surgery on another part of the body. Just because they do it every now and then isn't the doctor that you want to go to. You want to go to the specialist that's doing that regularly. That is their primary focus of surgery. You want to go to a specialist that has really good quality outcomes. So what are some quality outcomes we're looking at? Unfortunately, we are looking at mortality rates. You don't want to go to a doctor who has a mortality rate that's high. We're looking at surgical complications. Does this doctor require really long lengths of stay after they've performed the surgery? Are there any outlier cases out there? Are there really high cost procedures that's usually a red flag for something? We look at disciplinary actions and malpractice issues. You don't want to be going to a specialist that has those on their records. And then network participation. That's really important. I think patients are a little bit more savvy nowadays of being mindful that they're going to a doctor that's in network. Unfortunately, a lot of times they're not getting the accurate information. They're calling a provider's office, they get the front office staff, they'll ask, do you accept my insurance? Do you accept my insurance is very different than network participation. So you want to make sure that you're steering patients not only to a quality provider, but one that's also cost effective for them so that they can have a really good health outcome.
Colleen, may I just while you're on the subject of disciplinary and malpractice issues, should those folks even be in the network? I mean, aren't networks supposed to be getting rid of those folks in the first place?
It's so funny that you should ask that. Not only do we get that question about what are your credentialing procedures when you're actually bringing in a provider into your network. Most of the time, it's just that doctor is going to accept the reimbursement rate of that plan. They're not looking at any of that background information. So that's probably, if we were to do a myth page, that would be a really good myth that these networks are checking to see if there's any malpractice or disciplinary actions before they bring the provider into the network. Another question I get asked is, what about these big healthcare systems? Aren't they checking those as well? No, they are not. So it's really, it's really on the patient to make sure that they're identifying a quality provider, and by accessing an advocacy program like ours to help them make sure that they have all of that information when they're making that decision.
Great. Well, thank you. Okay. And so the next part of this is, once I have the data and you've pulled the data that you want, it's funneling that data down to the actual doctor decision. Ed, would you like to elaborate on this?
Sure. When you're looking for a preferred provider, what we're looking at here is some market area. This is an area in Pinellas County, Florida, where we look at how many physicians are performing a certain procedure. In this case, we're looking at a total knee replacement. So there are 60 doctors, orthopedic doctors, in the marketplace that meets the participants' criteria for distance and travel. And so then you determine, first step is, of the 60 physicians, how many of them perform procedure at least 50 or more a year. Now, that's our criteria for total knee replacements, 50 procedures. To be proficient in that procedure, we feel like that's a good number that's been verified by different institutions, that's at 50. So now we're down to 14. Of the 14, how many of them are quality physicians? And quality, we mean, are they credentialed? Are they board certified? Or they have any disciplines? Do they have good outcomes in the sense that their mortality rates are acceptable? Their complication rates, the number of outlier cases they have, how do they all fit in together? So now you're down to 8 physicians. You started with 60, and now you're down to 8. And of those 8 physicians, how many of those doctors are cost effective? And you look at the cost of the charges, you look at the cost of the implants, because implants is a pass-through item usually. And so that's the biggest variable that causes us not to select a physician because they're using prosthesis or a prosthetic device that's very expensive. So once you turn your definitions of cost, then you define those and you come down to 6 physicians. So of those 6, how many of them are participating in a network? Now, again, we're looking at the network of a PPO plan here, so that if you're 4 of those 60 are cost effective, have good quality, adequate volume, and are in your network, we would provide those names to the participant for a total knee replacement. We've also verified their participation in the network, and we've also verified appointment availability. So those criteria are taken into consideration within a network, so that we usually give 2 or 3 of those 4 positions to the names of the participants.
So this data all comes out of 2 databases, right?
Yeah, this is a commercial and Medicare database. So it's not just looking at only Medicare, it's looking at probably 95% of the cases of a particular doctor's in a general area. So we look at nationally commercial and Medicare. We may not look at too much at Medicaid, that's mostly in children, but again, for adults and commercial population, and Medicare contributes mostly to the hospital admissions. Again, we're looking at an inpatient setting here. So, you know, again, some of these procedures can be done outpatient, and we do take that consideration too. And now in total knee, some are done on an outpatient basis, and most of them still are done on the inpatient setting.
So assuming that perhaps shockingly somebody might not want to use Sentry, they can access this data on their own. From what specific database are they getting it?
Well, it's not so much having the database, it's also having software that runs this information to determine these particular numbers. You can buy data, but the question is you have to have a software package to be able to take this data and make sense out of it. And so, yes, you can buy information from the states, you can buy it from MedPAR, you can buy it from clearinghouses. A lot of places you can buy data, but the problem is you're not adjusting the data, so you're being able to benchmark and compare one doctor to another doctor in a geographic area. And that's what we provide. It's the analysis of that and determination of who is the best doctor for your specific need in a general area. And do you need a second opinion, which we'll get into in a second.
Okay, thank you. And our next slide here is about kind of a specific example, Ed, about choosing a heart surgeon. Would you like to elaborate on this one?
Yeah, this is a bubble chart that we've used over the years, and this is actual data looking at a general area. And in this case, we're looking at 9 bubbles or 9 physicians that meet the criteria of at least 75 open heart procedures per year. And again, when I'm saying 75, I'm referring to not just Medicare, but commercial and Medicare population. How many of those procedures are performed? So of the 75 or more, and again, the smaller bubbles are 75 and the bigger bubbles are up to 250. What we do is we index, in this example here, giving you a little bit more information about quality. Quality we view as either complications or mortality. There's also outliers, but again, looking at those 2 factors that we could get on an exhibit are important for us, because in complications, the question is, how many complications did the physician have, and benchmarking that against the other physicians. So an example maybe of mortality would be the doctor had 7 deaths and the population, we expected 10. So if 7 divided by 10 is 0.7, so that would be to the left of the 1. In other words, that would be better. If it was higher, obviously, if we had 10 deaths and there only should have been 5, it would be over on the right-hand side, and it would be worse. So again, we look at the actual results of a physician by procedure, not all of their procedures, just the procedures associated with what we're looking at. In this case, open heart. Now, obviously, these physicians are qualified, all of them are qualified to do it, but we picked A, B, and C because we felt like if you have a lower complication rate and a lower mortality rate with high volume, those are the doctors that I would use for my own family or myself. And with the data, it's quite easy for us to determine who those physicians are within a general area.
Okay,
Great.
so we have a few questions that have come in. One is that we'll send everybody the different ways. If you want to get the raw data, we'll send you how to get the raw data. So that's question 1. Question 2 is you set a minimum of 50 total knees. I had assumed that was because there are many markets in the country where the highest volume orthopedists wouldn't be doing more than 50. It's been pointed out that in major metro markets, you should be able to find people who are doing 200 or more, and they should have a higher quality. How would you feel about that?
Well, I mean, we have a physician in Florida who does about 800, and we don't use him, not because he doesn't have high volume, is just his outcomes are very good, but he has a habit of doing surgery on everybody. Just because they have high volume doesn't mean that's the right doctor for us to select. You want to select a doctor that has good volume, not necessarily the highest volume, but very, very good volume in taking care of the patients. We don't want the physician to have a different standard of care than the community. So again, we do want to use high quality, high volume physicians, not necessarily the one that has the highest volume, because again, the standard of care is what we're measuring.
Yeah, we have that in Quizzify as well, that it's a bit of a red flag if somebody does a ton of stents, a ton of joint replacements, a ton of back surgeries. So I'm glad you have the same. Mark, did you want to add anything?
No, we're going to move to our next section here, which will bring out the cost versus quality. And we've got 2 more polling questions here that I'll put up on the screen and give everybody a chance to think about what we're going to be talking about in our next section here. And we've got an example of an actual comparative hospitals and physicians. But there's a couple of questions. One is the relationship between cost and quality in the medical marketplace. What is it? And the second question is about the cost of providers. And it's an interesting question in the sense that it's at one hospital in Florida, what's the disparity in pricing for a total knee replacement between different physicians? And there's numbers that you can take a look at. And once we finish these polling questions, we're going to actually go into some data. Does anyone have a comment in our panel while we're waiting for these answers?
Yeah, actually, I have more stories. So once again, what I've done, the mistake I make is just take my PCP's word for these things. So I used to host a radio show down on the NPR affiliate in Washington, D.C. Don't ask why, it's a long story. But after my first episode, the producer said, okay, this, if your first time, that was pretty good. You'll sound better when you get over your cold. This is the way I normally sound. And apparently it was going to cost me this gig. So I called back to my PCP and said, can you get me to see an ENT? Because years ago, someone had told me that I had deviated septum or something. So, you get graded on satisfaction. So one of the ways you satisfy your members is getting them all the medical care they ask for. So she gets me in to see an ENT. Well, the ENT puts a scope up my nose and says, well, deviated septum's the least of your problems. You have polyps. I think, oh my God, polyps, I'm going to die. I didn't know what they were. So she says, well, there's 4 things we can do about them. She says, we can take them out. They could grow back. We can treat you with a 3-week course of antibiotics and Flonase. We could do Flonase alone. And she says, those are the 3. And I said, oh, and we're going to want a CAT scan of your sinuses. So the first thing I said was, well, shouldn't we do the most conservative therapy first? And she said, quote unquote, direct quote with the exact intonation, well, you could, meaning like, only an idiot would, but you could, right? And then the other thing, and mind you, this was somebody who was salaried, so it wasn't like she was trying to pitch me on a surgery. This is just what she does. She does surgeries. The other question I asked was, well, I don't think this is bacterial. Why would we do 3 weeks? It's a huge length of time for an antibiotic. I didn't say that. Why do we need an antibiotic for 3 weeks? She says, quote unquote, well, my patients get good results with the antibiotic. And I'm thinking, I got to get out of here, because you do not give people, first of all, that's not a reason to do anything. And second, you don't give people an antibiotic if they don't have a bacterial problem. That's a big Quizzify thing. I'm not going to get the CAT scan. I'm going to get out of there. So I got to like make a deal here, to get out. So I said, why don't we just do the Flonase? She says, fine. It says on the bottle, once a day, you can take it twice a day. So I say, fine. 2 next things happen. One is I go home, they've already tried to schedule this CAT scan for me. Someone has already called. And I'm thinking, I'm just going to ignore this. I don't want somebody, pointing radiation at my head. So I just ignored it. They called back and they called back a 3rd time. I'm thinking, if I don't call these people, they're going to charge me. So I called to cancel the CAT scan that I never wanted. So I'm just doing the Flonase for my hoarseness. And then at one point, I actually stopped to read the label on the Flonase, right? It says side effects can include hoarseness. Okay, so I'm going to say, I stopped taking it right away. That's not even the end of the story. The end of the story is I get, number one, I told the producer that this just wasn't working out, She said, oh, don't worry about it. We'll just give you some tea with some honey and just sip it, between comments. And in fact, the show did go off the air, and got, whatever the complaints came in, nobody said this guy sounds like he has polyps, so that part really worked out. Number 2 is I got a nasty note from the PBM saying, you haven't filled your Flonase renewal. Number 3, this is actually the only, well, actually 2 pieces of good news is one is this story, which was in the book. It's in Cracking Health Costs. Got back to the CEO of it's a $2 billion medical organization, actually. And he looked at it and said, we need to have this guy on our board so he can help us, prevent us from doing those things in the future. And I did, and I have been. We've just sold to Optum, but I was on the board for several years. And the 4th thing is, this is why I started Quizzify, because I'm thinking, if this kind of medical care, completely unnecessary and possibly harmful medical care, can be thrown at people, it's not just me, it's everybody. And that's how I got to Quizzify. So that's the story. Let's go to the poll.
Okay, we can share the results here. And for the first question, we have a pretty sharp group here. The answer, high quality healthcare is often the lowest cost, which is a true thing and very interesting component of the medical marketplace in the United States. The second question is an interesting one, and that actually goes into our next slide here. At this one hospital, at the same hospital in Florida, what's the difference in cost for a knee replacement for different specialists? And the most commonly chosen answer, 43% picked $25,000, 33% picked $75,000, 18% picked $100,000, and 6% picked $10,000. The correct answer is $100,000, and that leads to our next slide here that we're going to talk about here. And Ed, would you like to elaborate on this?
Yes, in this example, we're looking at a lot of numbers. I apologize, but we'll try to focus on some of the numbers. There are 3 hospitals we looked at, and within the hospital, we showed a range of the charge masters, and also some factors that contributed to that, such as length of stay. But an example of Morton Plant Hospital based in Clearwater, We look at physician on the very first line. It says 254 cases. And if you look at his length of stay is quite good, 1.38 days. And you look at his statistics, his charge master, charges that are associated with that physician at that hospital. In other words, the next hospital physician down shows the high quality doctor does 86 at St. Anthony's. And the next hospital down below that is Nice Countryside, where a physician's performed 100. Again, what we do is we kind of benchmark each of those doctors against each other within a general area. But within these hospitals, that specific hospital using a chain charge master, you can get a doctor both performing at least 50 total knee replacements a year. And the one doctor that performs 100 has a length of stay of 1.34 days. The one who performed 53 had a length of stay of 3 days. Same hospital, just again, the physician's controlling the length of stay. But if you go into the red, you look at the charge master, one doctor that performs 100, his average billed charges is $51,210 per case. The other doctor at the same hospital, 53 cases, 3-day length of stay, used a different type of implant, had a longer OR time, and could generate a charge of $153,000. Again, what's important about these billed charges is what you pay off these charges. And even Medicare pays more, but again, commercial pays more. But we use this data to be able to determine payment and also determine in reference-based pricing the amount of balanced billing or exposure. So if you use the doctor who has 100 procedures, you'd expect a balance bill of about $34,000. Whereas if you use the doctor with 53, that physician's balance bill will be $123,000, almost a $90,000 difference. So again, when you're selecting a physician, we're looking for outcomes, we're looking at costs, and this is just an example of some statistical cost information we consider when we're picking a physician.
Great. Thank you. Okay. So after looking at this data, we've determined the high quality physicians on an outright basis, and then we can adjust that for to put cost into the equation as well, so that when an employer is looking for physicians that are high quality and also a reasonable cost, this data can also be very relevant. And I think that spills into the next slide. Al, would you like to elaborate on this?
You mean Ed?
Ed, yes.
Sure. This is an example of, this is MedPAR data nationally. And looking at just only Medicare recipients. And you say, who are the top 4 markets for a total knee replacement? And NYC facility is Specialty Hospital of New York. And again, what we all tend to look at are the averages. In this case, it's $71,000. But what you really need to understand is the breakdown of the hospitals, each hospital. The range of the bill charges for a specific procedure can range in this case, $45,000 up to $84,000. It's all over the board. And again, the driving force behind the variations are the physicians. Again, they control length of stay, they control the OR time, and they control which implants they purchase through a hospital system. If you compare every hospital, you'll notice the range is quite significant. Some charges masters are like in Delaware and is significantly less than New York Specialty Hospital, where the average is only $30,000, but the range is from $27,000 to $49,000. Again, in Duluth, Minnesota, it's 21 to 62, and in Portland, Maine, it's $30,000 to $125,000. So again, the doctors based on outcomes, based on quality indicators, and now looking at also the cost factors. The green bubbles are the doctors that we would suggest a patient to see. And when we give the names out, we also look for appointment availability. We look at provide them a list of questions. Again, the list of questions is important. We'll get into in a second, because it's how do you talk to a doctor and how do you educate the consumer about talking to a physician about a specific procedure, and what's really important to understand and walk away with understanding from the physician the next steps. And so again, what this data really represents is a range within each hospital. And I know there's a difference between each hospitals, but within the hospital, there's more variation than comparing the facilities to the other facilities in the same geographic area.
Well, so are you saying, let's take the New York Hospital for Special Surgery. Are you saying that
Sure.
that if I am, say, Aetna, and I have a particular procedure code for a total hip replacement, and it doesn't, there's certain procedure codes where there's like more complexity, you know, for a given procedure. You're saying that they get different bills from the New York Hospital for Special Surgery based on who the doctor was, that they didn't negotiate a price for a total joint replacement, total hip replacement?
Yeah, every procedure by hospital, if you had 10 different patients with Aetna, the amount of those bills would be like this. It could be $45,000, $50,000, or it could be $80,000. Now, again, it is not necessarily the patient that's that much different. It's a physician that's different. Physician will use a certain implant. It takes a physician longer to perform a surgery. The doctor takes longer to perform a surgery. What does that mean? It means your anesthesia bill will be higher as well. So there's lots of variables that doctors control, and it's not necessarily always the length of stay, in this case commercial, compared to commercial or Medicare to Medicare. It really is the physician that's the biggest variable, but there are always going to be differences. It doesn't make any difference what procedure is. The bills are all based on a la carte master charges, and based on how the coding and so the bills will all be different. In this example, every one of these hospitals for the exact same procedure. This is not a revision of the knee. This is just a total knee replacement. And some have complications, some don't. Not too many have complications. So the biggest variable here is we use this example in total knees because it shows the variation of what a doctor controls within a certain hospital system.
Okay, thank you. We have some questions coming in. We're going to get to all these at the end. We do want to cover the material we have here, and the next part is about actually once you've found the right specialist who is in a reasonable cost range, then you need to engage your employees. So, Colleen, would you like to talk about this?
Sure. So I think, the first thing we really need to focus on is education. Education is key here. The who, what's, when, where, why is what needs to be focused on. Hopefully we've got the why down. Why is it important to use data when making a decision and choosing a specialist? And I'm going to assume that most of the people today on the webinar are really smart and intelligent. It's being able to take that information back to the employees and help them understand that they shouldn't be taking these decisions into their own hands, that they should be using some experts to help guide them through making that decision. Again, it's that idea of the iceberg, of not just focusing what they can see, but it's everything underneath that they need to be able to consider when making that decision. I think also it's the timing of the education that's really, really important. You really want to get your employees engaged sooner rather than later. And what I mean by that is it's much easier to steer a patient to a quality provider when they first start having signs and symptoms of an issue than trying to come and have them change their surgery date because they're linked with a provider that has poor quality outcomes. So you really want to focus on education on the timing of having patients engaged earlier rather than later in order to get them some really good quality outcomes. So let's talk a little bit about the who and how. So how do you get that message out? I think one of the things is you really need to use your contacts within the groups as allies. So HR is usually a really big ally to make sure that they're getting the message out there. They're also usually the kind of the boots on the ground where they will hear things or they'll hear about patients or employees having issues, and they can kind of remind that there's a service out there that can help patients make really good decisions. Open enrollment is a great time to kind of educate your employees, but you have to remember open enrollment is also a time where they're getting overloaded with information. So you want to make sure that you're spreading that message all throughout the year, whether that's e-blasts or reminders or postcards. You don't want to just focus on that one and done. I think, in terms of navigating, it's really important to consider who's providing the guidance to the employees. And I think having a nurse, a clinical person is really key. And why is that? I mean, I'll tell you from my perspective, from an operations perspective, it is not cost effective to have clinicians, nurses guiding our patients. However, I think it's such a critical, important part of that. A nurse is going to be able to pick up on things that a layperson isn't necessarily going to be able to pick up on. They're able to kind of redirect the patient to go and get the right care. I can't tell you how many times we'll get calls for a patient who has back pain, who wants to see an orthopedic spine doctor, and really it's more of an issue with, let's say, their kidneys. And so a clinical person is going to be able to get the patient to the right specialist, and that's really important. Maybe the patient without a nurse would have gone to an orthopedic and the orthopedic would have been able to re-steer, but then think about that employee who's now gone down the wrong path. They start to get discouraged, they start to get frustrated. Now they've taken time off of work. So all of those types of things come at a cost. I think the nice thing that we have here is we have an opportunity to be really creative in our plan design and really offer incentives for employees to engage and follow through with the recommendations. So, with the self-funded plans, you get to make the rules and you get to have a little bit of fun here. So you can really encourage patients to utilize the services to engage with the program by offering incentives. And it doesn't have to be anything complicated. In fact, I recommend that the simpler, the better. But I've seen incentives such as specialist copay waivers or deductible waivers or even HRA contributions. And that really gets employees excited and engaged in the program. So kind of consider that when we're coming up with a plan design that maybe would use some type of navigation program. I'll turn it over to Ed to talk a little bit about the implementation of that.
Yeah, I tell you, the broker's role on designing the incentives is imperative. And I think that the cost analysis part, tying in with the advocacy services to the paid claims is critical. In other words, we spoke to 50 patients who are having surgery. How many of those 50 actually use those doctors and follow through with the facilities that we suggested they go to? So looking at your analysis of paid claims to the advocacy services, it's critical to determine the effectiveness of an advocacy service. We're doing that at Century, where we're tying in the payments with the advocacy with the complete steerage of the population. And also doing predictive modeling, I think is important too, is analyzing the data with the specialists to make sure that we stay ahead of the game and being proactive in dealing with that population.
Now, can I just ask a question? Because you talked about specialists waivers for the specialist fees and stuff, and trying to get people early to get referred to specialists. I think there are a lot of folks on this call who might say the opposite, that if you have a good advanced primary care model, you try to get as few specialist referrals as possible. And the last thing you would want to do is waive a copay for a specialist. So how do you reconcile?
And that is, yes, and that is why it's so key to have a nurse kind of running the program, right? And so they're really able to screen when it's an appropriate time to engage with their primary care doctor versus when it's time to link with a specialist. So we're constantly redirecting patients back to their primary care when it's appropriate. I have a really good example of that. We had a patient who called us and they wanted a neurosurgeon for headaches, a neurosurgeon, not a neurologist. So we were already off on the wrong foot. But with some assessment, the nurse was able to determine it was likely a high blood pressure issue that was causing the headaches, and was able to get them redirected to their primary care. Issue was resolved, didn't need referral to a specialist. And so again, I think that's why it's so important where you have a clinical person really helping make an assessment. I know we live in a day and age where we're so used to having data at our fingertips. And I can see some of the, the stuff coming in while we're doing this webinar, and people want the data, they want the data. The problem with just having the data is if you don't have a person who's really understanding what that information means and assessing for whether it's appropriate for the patient to engage with a certain specialist, you can have a really poor outcome. So, having access to the data is just one piece of the puzzle, and making sure that you're getting a patient engaged with the right specialist at the right time.
Well, thank you, Colleen. Okay, and that leads us to our next section here. And I'm going to put up our last polling question here. And I'm going to ask Al Lewis to take us through this here.
All right, I got to just close this out. So now that you've found a good specialist, what questions do you ask? Okay, so we'd like you to fill this out, but this is actually what Quizzify to Go is all about. It's lists of questions by topic, 110 different topics. And Mark, after we put this up, and we'll go to Quizzify to Go. I did have actually I got a bunch more stories, but I did have one more story worth telling. Is that my daughter, who was a dancer, was an aspiring dancer back then, and she had a hairline back fracture, and we went to we were referred to an orthopedist. Now the orthopedist wanted to do a CAT scan. And knowing what I know about Quizzify now, I would have said two things. I would have said, what are we going to learn from that CAT scan that's going to change the course of treatment? Because the fact is, if you have a hairline back fracture, there's nothing you can do about it anyway. You just have to rest. I did not know to ask that question. The other question I did not know to ask is, should we really be doing CAT scans on the abdominal region of a teenage girl? And the answer, of course, is no. That's what you would have learned in Quizzify, and that's what I didn't know. So we got the CAT scan. Of course, nothing happened as a result. And my daughter is still upset with me for letting her get that scan, even though I said there was no Quizzify back then. I did not know to ask how much radiation was in that scan. So what do we have here, Mark? Okay. This is good. I said Quizzify to Go to prompt me, and I swear I did not, none of us actually participated in this poll. So the correct answer is in fact the last answer, which is to be prompted with the right questions on the day of your visit. Okay, so I'm going to just I just close my screen here. So here is a classic Quizzify question specifically to gently discourage people from exactly what Ed and Colleen are talking about, which is getting unnecessary surgery. We don't say don't get unnecessary surgery, because we found early in Quizzify that if you try it too hard to convince people not to do something, the backlash from the employees is you're just doing this to save money. So now we're much more subtle about it and making sure that the employees can come to their own conclusion. So this question, note the Harvard Medical School seal, which is on all of our clinical material. What is the #1 diagnosis leading to a spinal fusion? And the answer is a failed spinal fusion. This turns out to be about, somebody referred to it once as our generation's lobotomies, that years from now, they're going to look back and saying, why were they doing that? Now, the fact is that they are doing more than ever because they're shifting to outpatient, and it's much easier for a patient to agree if it sounds like a minor procedure, not realizing that the issues are going to take place down the road. And Mark, I think you're still the screen sharing, right?
There we go.
Okay. So now one of the questions that we used to get in Quizzify is, well, that's great. You're teaching folks all this stuff, but what if they forget? What if they take a question on, say, back pain in February, but they don't start experiencing back pain until, until June? Well, the answer is that's Quizzify to go. And Quizzify to go for more than 100 different topics lists the questions that you should ask your doctor. And it always starts out with a paragraph. And I have mentioned before that the classic thing about back pain is that 80% of it goes away on its own, but we at some point, virtually everybody with back pain for more than a week is convinced they are in the other 20%. So that's the first thing you should know. And then you have all the questions here to ask. You can click on playing a Quizzify quiz on back pain. You can actually email this to other relatives of yours or friends, and you can actually calendar it. But now we're going to see how incredibly convenient it is. We're going to do what we call the Quizzify challenge. The Quizzify challenge is you put, we have here a, this is Quizzify to go. As mentioned, it has more than 100 different topics that are going to expand. And all you need to do is enter a keyword. So I'm going to challenge you to enter a keyword, just any old keyword, just put it in the chat box. And we're going to see if let's say you need to go, I mean, this is an easy one. If you're pregnant, you enter pregnancy and you're going to get 3 or 4 different topics, depending on where you are in your pregnancy. So what do we have coming in here on the chat? Okay, diabetes. Okay, we have a bunch coming in. We just did pregnant. Diabetes is a good one. So let's see what happens if you get diabetes. For diabetes, you get there's
4 categories there.
Actually, it looks like there's 8 categories.
Yeah,
well, there's 8 different things that you could ask. Let's click on diabetes and see what pops up. I think you just
the follow-up exam or initial diagnosis.
Anything, yeah.
Initial.
So then these are the questions that you ask on the initial diagnoses. The other thing about diabetes is that there are a ton of ways to actually be increasing your sugar that you don't, your dietary sugar that you don't know about. And it's important to learn about those, not just from your doctor, but also from Quizzify. So it turns out that I've been getting this green juice, or one time got this naked green juice from Whole Foods that looked very healthy, but it had more sugar in it that even, it says no added sugar, but it had more sugar in it than a can of Coke. Now you might say, how can they do that and say no added sugar? That's a Quizzify thing. And the answer is that if you're a juice and your added sugars are concentrated fruit juices, that doesn't count as added sugar. And I don't make the rules, So we have a whole bunch coming in here. Joint pain, you can just put in, see joint pain shows up different ways. Low back. Joint pain can be caused by tick bites, so you want to make sure you cover that. Now, somebody put in endometriosis. I don't believe we have that, because you typically wouldn't go to the doctor and say, "Doc, I have endometriosis." You would go to the doc with a symptom. So we've got plenty of symptoms in here. We've got plenty of symptoms and reasons to go to the doctor, but not necessarily specific clinical diagnoses. Having said that, I see it is a common diagnosis. And one of the things about the Quizzify challenge is occasionally we flunk. And when we do that, we take the word, which is endometriosis, and along with our friends at Harvard Medical School, we research and we'll come up with a number of very good questions to ask for that topic. So we'll be filling that topic in. One of the things that we get all the time is, well, this is great that you have this list of questions, but what if, number one, what if we forget to bring our phone? Well, who forgets to bring their phone? But number two, more importantly, a lot of patients are reluctant to ask these questions, right? So we have that handled in the PS. You know, we just say, look, this is just something I have to ask if I'm going to get reimbursed, right? You know, I got to ask these questions. I'm sorry. So if you're a little bit shy, we're happy to take the blame.
Now, there's a question here: is how is this different from free info on the internet, such as the Mayo Clinic, WebMD, etc.?
Well, have you ever seen anything like this on the internet, where you just put something in and you get a list, and it folds out into the specific questions, and you can put them in your calendar, and you can email them to friends, and you can take quizzes on them. Now, the fact is, we do actually get some of this information that we don't get from Harvard. We get it from Mayo Clinic. We even get it from WebMD, which is actually a shockingly good source of information, I have to say, even though it's commercial for profit. The value add for Quizzify to go is to put it all into one convenient, calendarable place with quizzes laid out with links so that you can see it at a moment's notice. You don't have to be searching all over the internet.
Okay, and I'm just going to go to one of the questions here. This came up in a couple different places, and again, we're going to answer the questions we didn't get to independently here. But the question is about kind of bundled payments, and we know that that's a strategy with next generation strategies. Ed, can you comment on how your service may work with a bundled payment plan, or how it's different? So that becomes clear to our audience?
Yes, well, it's interesting. We were evaluated by the Validation Institute, and we were evaluated for looking at how we select physicians, reference-based pricing, and bundle pricing. So we won, actually 2 years ago, we won for bundle pricing the Validation Institute award for those services. So we can coordinate within our own services, and we can coordinate with other companies on bundle pricing. So we bundle price with ambulatory surgery centers, with hospitals, on just about any procedure there is, looking at the specialist, looking at the anesthesia, and looking at the facility. So we perform that service internally within the Century wheel of services.
All right, and our last, so one other question here specifically about the knee implant is, if one of the factors in a knee implant is the cost of the implant, couldn't a more expensive knee implant be potentially better fit for a specific patient?
Well, this is Ed. In my opinion, the implants, some are a lot more expensive than others, but statistically, they're not any better. And so basically, we steer our patients to those particular physicians that have cost-effective implants, not necessarily the ones that are much more expensive. I can't think of a situation where, again, in a knee, it's more important to, I think, use physicians that use computer-generated alignment systems to make sure that the implant is put in correctly than using a more expensive implant themselves. So the process and procedures, I think, are more important than the actually implant themselves, as far as we can tell.
And I will just wrap up with one thing to that point, which is that because the FDA has a huge loophole in how you get new implants approved that does not require them to be tested, and has led to disasters like the Cobalt hip for J&J, that on its own is enough for me to go with a standard implant that's been around for 5 or 10 years rather than a new high-tech one that looks like it's been tested but hasn't. And on that note, I think we're out of time.
We are, yeah.
Mark, isn't it 1 o'clock?
Yeah, thanks, everyone. Everyone's going to get a copy of the slides as well as a recording of the webinar, and we're going to answer all these questions that you sent into the question box. And thank you, everyone, for attending. Thank you.
Thanks.
Thank you.
Bye.
Bye, everybody.